Dear colleagues, my name is Darko Chudy and I am from Zagreb, Croatia. I will present to you deep brain stimulation in a patient with disorder of consciousness. A review of the literature revealed us that Hassler and others in Germany in 1969 started to use chronic stimulation for patients in coma. The target area for stimulation they used was thalamic nuclei and globus pallidus. The most used target point throughout the literature was centromedial parafascicular nuclei of thalamus. The Kohadon in France and Tsubokawa and Yamamoto in Japan used this target point. The definition of vegetative state is according to the text of Multi-Society Task Force, which was approved in 1994. So there is no evidence of sustained, reproducible, purposeful, or voluntary behavioral responses to visual, auditory, tactile, or noxious stimuli, and no evidence of language comprehension or expression. In 2002, Joseph Giacchino established a minimal conscious state characterized by inconstant but clearly discernible behavioral evidence of consciousness and can be distinguished from coma or a vegetative state. We used Rappaport coma near coma scale to compare the level of consciousness among the patients and in the same patients before the deep brain stimulation and several months after, up to 1 year. The level 0 was awareness and level 1 was minimal conscious state. Level 2, 3 and 4 is vegetative state. What is the Rappaport coma near coma scale and which brain input and output are scoring is presented on this slide. Definition of consciousness is the matter not only of neuroscientists but also physicists, philosophers, religion authorities and many other. What is the consciousness, how and who or what created, and what is the aim and how it is finished? This is the question which wonder approximately 7 billion people around the world. The neuroscientists trying to find out how our brain works and in which part of the brain could be the consciousness. But we as a pragmatic medical doctors are only trying to help our patient in the best way and many times throughout the history without knowing the proper scientific explanation. So the main reason why we use centromedial parafascicular nuclei as a target point is empirical. This thalamic area is the most used target point and has the best results compared to other target points for stimulation of patients with disorder of consciousness. Even more, for this target point was shown that somehow it rises the level of awareness, and from 107 patients who fulfilled neurophysiological testing, 21 were stimulated and 8 of them recovered. None of the 86 patients who also fulfilled neurophysiological testing recovered spontaneously. From 2011 to 2040, we used deep brain stimulation in 14 patients, 10 patients in vegetative state and 4 patients in minimal conscious state, mainly as a result of ischemic lesion. Electrophysiological criteria were as it is described on this slide. We used centromedial parafascicular thalamic nuclei as a target point, and according to the Schalterbrand-Bailey atlas, the target point was 3.5 mm in front of the posterior commissure, 4.5 mm lateral from the ventricle wall, and 1 mm below the ACPC plane. On this slide, we present a 70-year-old boy who admitted to our hospital. Video present the patient with post-ischemic myoclonus.
Josipe! Hey! Hey!
After the cardiac arrest and reanimation, the patient sustained in a minimal conscious state. The initial magnetic resonance imaging 2 days after the incident and 2 months later showing marked brain hypertrophy after the ischemic lesion. We stimulated the patient for half an hour, then 3 hours without stimulation, and again half an hour stimulation during the daytime. The parameters of stimulation are written on the slide. And this video presents 2 months after beginning of deep brain stimulation. Patient and our results were as described on the slide. So from 4 patients in minimal conscious state, 3 patients reached the level of awareness, and only 1 patient in a vegetative state from a 10 patient reached the level of awareness. We present our result in a paper in Journal of Neurosurgery 2008. On this slide, we present, and this slide shows how fast was the recovery from the minimal conscious state after the deep brain stimulation, which is somehow proportional with the time of beginning of deep brain stimulation after the incident. This video shows the patient in vegetative state who sustained the level of awareness.
Matea, tu sam, ljubavi. Bog. Matea. Matea.
And this is a video which presents the same patient 10 months after the start with deep brain stimulation, and the patient now is following simple command.
Matea, jel me čuješ, ljubavi? Ajde spusti desnu ruku. Ajde ju digni ponovo. Ajde ju spusti. Drži ju tako. Digni ju gore. Bravo!
And not only with the limbs.
Matea, da vidim jezik van. Jezik mi isplazi van. Ma to! I vrati ga nazad.
In almost each patient we could elect arousal effect, which are characterized with the opening eyes, higher blood pressure and heart rate.
Pacijentica nije stimulirana. Pacijentica je stimulirana.
Na 3,5 volt. 3,5.
Na 3,5 volt.
We describe this phenomenon in our paper. The first description of arousal effect was in the paper from Hassler, although the amperes and voltage was much higher than nowadays we use for deep brain stimulation. Almost in all papers dealing with chronic stimulation of patients with disorder of consciousness, the arousal effect was described. The authors from Japan used arousal effect as an indicator for the proper position of active contact. We measured in each patient the position of electrode on post-operative CT scan. I will just briefly mention some pitfalls and difficulties of deep brain stimulation in patients with disorder of consciousness. All patients have a huge brain atrophy, so sometimes avoiding sulci and ventricles is quite challenging. We used fibrin glue to avoid huge loss of CSF and pneumocephalus as a consequence. On this video, you see the artifact from the lead following exactly the preoperative planning surgery. Sometimes not only brain atrophy, but loss of subcutaneous tissue is so huge that even neurostimulator is impossible to implant. In some patients, we should implant not only neurostimulator, but also defibrillator because of heart failure. It is very well known that the CAT therapy for patients with disorder of consciousness is under specific ethical consideration. The Italian public was aware of a patient Elwana and Glaro who had been in vegetative state for many years. After several years of trials, the passive euthanasia was implemented. Majority of patients who sustained awareness are severely disabled. This young girl was in a minimal conscious state after the traffic accident. Now she is a fully consciousness and also conscious of her severe heavy paresis.
To? Stani, 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 izdrži, 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 još, još. Ajmo u korak. Ajmo u korak s desna. Dobro.
So, is it ethical to make someone aware of being severely disabled? Care for the patient with disorder of consciousness is very complex, and so the teamwork is needed even more than in some other neurosurgical procedures. As a conclusions, our data as review of literature are highly indicative that the deep brain stimulation of particular nuclei could have positive effect in a patient with disorder of consciousness. Further clinical studies and scientific work are needed to confirm and reject our hypothesis that deep brain stimulation has significant impact on recovery in a patient with disorder of consciousness if it's implemented in a rather early stage of disease. The appropriate selection of the patient, neurophysiological or neuroradiological, is the matter needs to be investigated. Thank you for your attention and all the best from Zagreb.